Imagine sitting in a dental chair. You're young, your teeth feel perfectly fine, and you have absolutely zero pain. Yet, the oral surgeon looks at you and says you need surgery to remove 4 teeth. This panoramic X-ray shows exactly why. Beneath the gums, hidden from view, are 4 unerupted third molars. Dentists call these teeth impacted. They lack the physical space to emerge normally, permanently stuck against the jawbone or neighboring teeth. Our prehistoric ancestors consumed coarse diets of raw meat and tough plants, which required large jaws to house these extra grinding teeth. However, as humans discovered cooking and processed foods, our jaw sizes shrank, leaving no room for the third molars to actually fit. The absence of symptoms does not equal health. Many patients mistakenly assume that if a tooth doesn't hurt, it is completely harmless. Choosing to wait and see with a painless impacted tooth is an active decision. It starts a ticking clock for a progressive, invisible disease. Down at the microscopic level, the geometry of the mouth creates a trap. A partially erupted or mesioangular wisdom tooth, meaning it is tilted forward, forms a dark void under the operculum. The operculum is a flap of gum tissue that partially covers the crown of the tooth. Because this pocket is physically impossible to clean with a toothbrush, food particles and bacteria become permanently lodged inside. This inevitably leads to pericoronitis, a localized and highly painful inflammatory infection of the surrounding gums. The threat extends beyond the wisdom tooth itself. The bacterial trap actively attacks the innocent bystander right next to it, the second molar. This radiograph shows the direct collision between the teeth. The tight space fosters severe decay, known as distal caries. Distal caries are cavities that form on the back surface of an adjacent tooth. Because of the tight angle and poor physical access, repairing this specific type of decay is notoriously difficult. Dentists must often extract the wisdom tooth just to access the cavity. If decay reaches the pulp, it frequently results in losing both teeth. An impacted wisdom tooth operates as a biological Trojan horse, quietly compromising the foundation of the functional, essential teeth beside it. Zooming out to the jawbone reveals another risk. Completely submerged, asymptomatic wisdom teeth develop within a protective membrane called a follicle sac. Look at the massive, dark radiolucent void on the lower right side of this X-ray. In rare but severe cases, the follicle sac unpredictably fills with fluid, forming a cyst that physically hollows out the mandible. As this cystic expansion silently grows, it eats away the surrounding bone. This drastically thins the jaw's borders, weakening its structural integrity and significantly increasing the risk of a bone fracture. The danger also leaks out of the jaw entirely. The deep periodontal pockets around wisdom teeth act as gateways, allowing chronic inflammation and bacteria to breach the gum tissue and enter the systemic bloodstream. This systemic leakage introduces pro-inflammatory cytokines into the body. Cytokines are proteins that signal and worsen inflammation. Their constant presence in the blood is linked to severe remote health complications, including an increased risk of cardiovascular disease and kidney strain. An untreated impacted wisdom tooth is a structural liability to the skeleton and a chronic toxic leak into the cardiovascular system. Some patients opt for active surveillance, a strategy of keeping the impacted teeth and committing to a lifetime of continuous X-rays and clinical monitoring. They do this because the onset of the disease is entirely unpredictable. This visualizes long-term data for retained third molars. As a patient ages from 20 to 50, the statistical probability of disease development rises sharply. Ultimately, over 70% of retained third molars require surgical extraction later in life due to late-onset pathology. This creates a medical catch-22. If a patient waits for the tooth to finally cause pain before removing it, they are significantly older, and the surgical risks are much higher. The physiology of an older patient complicates the procedure. The surrounding bone becomes much denser, and the tooth roots fully form. These mature roots frequently wrap around or grow dangerously close to the inferior alveolar nerve, the major nerve supplying sensation to the lower lip and chin. Contrast this with patients under 25. Early surgery involves softer bone and incomplete root formation. This results in significantly lower risks of permanent nerve damage, prolonged morbidity, or a dry socket. A dry socket is a painful condition where the healing blood clot at the extraction site fails to develop or dislodges. surgery isn't mandatory for every single impacted tooth. However, understanding the high probability of hidden progressive pathology allows patients to act decisively, neutralizing an asymptomatic anomaly before it transforms into a permanent, painful consequence.